Welcome, everyone. My name is Jill Zacharias, and I'm a fourth-generation settler of mixed European ancestry. We begin this webinar today by acknowledging that we are meeting on Indigenous lands. The land that I am privileged to call my home is the unceded territory of the Sinaiaks, the Tanaha, the Shekwepem, and the Silks people. I am grateful for the opportunity to meet. The first people who knew and stewarded this land from time immemorial were integral to the story of the inland temperate rainforest and surrounded mountain ranges. Recognition of the contributions and historic importance of Indigenous peoples must be clearly connected to our collective commitment to make the promise and truth of reconciliation real in our communities. So feel free to use the chat box to acknowledge where you're calling in from and say who you are. And also to ask questions and share stories. We're really hoping to have time after the webinar presentation for dialogue. And as always, slides and recording will be sent out after the call. Want to just pop over to the next slide? Thanks. So, I'm really excited about today's webinar. At an in-person poverty reduction conference in Cranbrook, BC this fall, Jennifer Wright gave a powerful presentation on the interrelationship of poverty and mental health. We're excited to share her insight and passion with our members today. As Jennifer states, one cannot address issues of poverty and crime without understanding mental illness, and we are in a mental health crisis. Jennifer Wright is a registered clinical counselor and the owner of Columbia River Counseling and Neurofeedback here in Revelstoke, BC. Jennifer specializes in complex trauma for both children and adults, ADHD, traumatic brain injuries, neurofeedback, and neuromodulation therapy. Jennifer's career was launched in Colorado as a crisis counselor before relocating to Canada 5 years ago. Jennifer recently opened a second practice, the Kelowna Brain Sciences, to provide neurotherapy to the greater Kelowna area, and is currently developing a nonprofit crisis center for the town of Revelstoke that's modeled on the center that she worked for in Colorado. So we will turn it over to Jennifer to launch her presentation.
I'm honored to be here today to discuss how mental health interfaces with poverty. Thank you for the invitation. As you shared, one cannot fully address issues of poverty and crime without fully understanding mental illness. We are in a mental health care crisis, and what I hope to illustrate for you tonight is that community mindset and coordination among social sectors of care is necessary, are necessary and powerful components towards solving the discrimination against mental illness and those living in poverty. I'm going to share some content that may be triggering or emotional for some of you. Some of what I am sharing today is deeply emotional for me. So let's normalize that feeling uncomfortable when discussing mental illness is okay and even healthy. Today, I'm going to go over some common myths about mental illness, some shortcomings of our healthcare system, solutions, some real world success stories. As we sit here together today, we have more medicines, more research, more therapy, more providers, and more people engaging in treatment than ever before. And yet, more people are dying of or disabled by mental illness than ever before. In 2013, mental disorders topped the list of the most expensive medical conditions, and more than 2 million Canadians have a mental illness disability. Of those 2 million, 8.3% are living in British Columbia, totaling the highest percentage of any province. When I meet people in my office, I often endear them as my darling or my love. For today's presentation, I may occasionally reference people living with mental illness as patients, and I do this deliberately. I want the MSP and private health insurances to recognize mental illness with the same coverage as they give to people living with cancer or diabetes. And I want medical science to use the same standards of care for treating mental illness as they give to people living with heart disease or Alzheimer's. However, as we move forward in today's presentation, the conversations that follow it, it is critical that we remember labels such as client, patient, illness, disorder, disability, or even a diagnosis such as schizophrenia or borderline personality disorder are socially agreed upon terms that define a set of symptoms. They do not in any way ever describe a person. Thus, as we embark upon these conversations, we must be careful with the language that we use and not refer to a person living with schizophrenia as a schizophrenic. They are a person living with schizophrenia. Or someone living with addiction as an addict. They are a person who is living with addiction. And the minute we change that, we lose our human connection to them. On the street, within minutes, a response of concerned citizens and first responders will show up to help you, transport you to the hospital, where your injury will be examined and treated, and you will be sent home with the necessary medications and a follow-up plan for care. But if mental illness breaks your mind and you're living on the streets or behaving outside of our preconceived social conventions, the response is far less compassionate, competent, or even organized. Homelessness, incarceration, chronic medical problems, and early death are often the consequences of mental illness left untreated. Prior to the deinstitutionalization of psychiatric hospitals in North America in the 1970s, homelessness was not a large social problem in Canada. It was believed at the time that these patients would be better cared for at home and or in their communities than be subject to the horrific conditions of many of the hospitals at the time. But almost 50 years later, we can now see that the majority of those patients found themselves either homeless or in the criminal justice system. Today, we know that on any given night, a young person with psychosis who needs to be in a healthcare facility has a 50% chance of being incarcerated, a 25%, sorry, I always cry here. A 25% chance of being homeless and a 25% chance of being involuntarily hospitalized. 80% of people who are homeless have a serious mental illness, and 55% of the homeless population lives with an alcohol substance use disorder. Additionally, 3 out of 4 people in British Columbia prisons have a mental health disorder. We've been discriminating against people with mental illness for centuries. When we aren't on the same page and coordinated, we often assume that someone else is better equipped to respond to the mental health crisis. Leaving the mental health care crisis up to the medical and mental health care providers to fix is no different than leaving the climate crisis up to the field biologists who study it. So let's address some common misconceptions that I often hear in my office. Number 1, mental illness is the new fad. I hear this a lot from patients or parents, in my office, but it isn't just parents. You may be surprised to know that the American Psychological Association has also faltered under this stigma. When publishing the DSM-5, which is the manual used for psychiatry for diagnosis, they included diagnostic criteria for ADHD that is not based in science. I struggle to imagine medical science ever caving due to stigma at the expense of evidence diagnostics. Mental health stigma is pregnant with fear and avoidance that is the consequence of a lack of evidence-based, coordinated care and legislative funding. Stigma is oftentimes described by those living with mental illness as worse than the mental illness itself. As this suicide survivor shared, I had to decide, do I want to kill myself or do I want to see a psychiatrist? I hated myself enough to want to die, but not so much that I would become a mental patient. We do not need a magic bullet here. We already know how to effectively liberate people living with mental illness from the social isolation, discrimination, and human rights violations that is the consequence of stigma. We need advocacy, collaborative community-based care, social contact, networking, and psychoeducation. 4 goals for stigma reduction include eliminating workplace discrimination against people living with mental illness, the development of governmental policies to end stigma, developing curriculum for healthcare workers and educators that is led by people living with mental illness, and the removal of stigmatizing content from the media. Excluding people with mental illness from the development of our platforms is silencing the most experienced voices in the room. Dr. Insel, the former director of the National Institute for Mental Health, writes in his book, Healing, "To me, the word stigma invokes victimization and unfortunately inaction. I prefer the term discrimination, which heralds a call for social justice. Stigma by itself will not launch a civil rights movement to overcome systemic exclusion from care." Myth number 2, medications can fix it. 80% of psychiatric medications are not prescribed by psychiatrists. Because there are too few psychiatrists, general practitioners are often left holding the liability without the competence of specialization to help support their prescribing decisions. Further, due to stigma and side effects, adherence to psychiatric medications is below 50%, the worst among all prescribed medications. While many psychiatric medications are very effective, they're not meant to be standalone treatments for mental illness. Prozac will blunt the system, but it will never integrate it. Medication can suppress effects, but they will not train the brain to function optimally. If we compare the efficacy of Prozac after 8 weeks of treatment for PTSD, you can see that it's only 2% better than a placebo. Actually, there's been a lot of research studies coming out.
Oh, really? Cool. Post-traumatic stress disorder.
Can we just get folks to check their mute, please? We can hear someone talking in the background. Thank you.
I wasn't sure if I should cue and stop talking. Yeah, so post-traumatic stress disorder. And so actually, when you look at a lot of research studies right now, they're starting to recognize that SSRIs or antidepressants in general do not offer a clinically significant benefit. And therefore the use of them, we're starting to reconsider. However, if you look at EMDR, that stands for eye movement desensitization and reprocessing, which is an evidence-based trauma therapy. You can see that they get a 59% reduction in symptoms in 8 weeks, which is better than Prozac and a placebo. I once was in a class of Dr. Bessel van der Kolk's, who many of you may know is a leading authority on trauma in the world. And he said, if you can't get a 44% reduction of symptoms in post-traumatic stress disorder in 8 weeks, you're worse than a placebo, which is quite a lot of pressure. Myth number 3, there's always a hospital that can help. but there really isn't. Just full stop, there's not. This is perhaps the most heart-wrenching conversation that I have with parents. 75% of people with mental illness will report the onset of symptoms before the age of 25, which is why I mentioned earlier that we need curriculum for educators. And yet there's virtually no mental health care system for youth in British Columbia. Last winter, I sent a family to the emergency room with a young girl who was suicidal and experiencing her first episode of psychosis. At the time she was admitted to the emergency department, there were almost 6,000 youth waiting on 24 beds in BC. The attending physician was given the same automated response from every psychiatric hospital he called. If the patient is not actively trying to kill herself in your emergency room, or she is not in a drug-induced coma, we do not have room for her. And if she meets one of those criteria, she will have to go on a wait list. The Canadian Mental Health Association reports that an estimate of 84,000 children and youth in BC have a diagnosed mental illness, yet less than 1/3 of those children who seek help are receiving mental health services. That means that as many as 58,000 children in BC are not receiving the treatment that they need. Further, BC has only 24 publicly funded treatment beds to serve our youth. When it comes to adults living with mental illness, it doesn't get much better. Among developed countries, there's an average of 71 psychiatric beds per 100,000 people. If you look at this chart here, is 35 of the most advanced countries. Canada comes in 29th, offering only 30 beds per 100,000 people. Additionally, the occupancy rates for a psychiatric unit should never exceed 85% for optimal functioning of the unit. And yet psychiatric hospitals in BC are often running overcapacity protocols. For those who are able to find a bed, the pressure on the system is so great that they are often discharging patients prematurely with no follow-up or coordinated care plan for community-based services. If a doctor discharged someone racing for their life from cancer, racing for their life against cancer from the hospital prematurely, and with no financial access to the medications necessary to save their life, and with no coordinated care plan or communication among providers, we would call that malpractice. Myth number 4 is that we believe people in need will seek help on their own. But this is really not the reality that we see. The more severe the mental illness, the less likely an individual will seek care. Some people with serious mental illness don't recognize that they have an illness, so they reject care. Hopelessness that accompanies depression will prevent people from reaching out. Distrust of others is a common symptom of post-traumatic stress disorder. It's also a common symptom of people who have experienced developmental trauma. And people with anxiety know all too well that avoidance is anxiety's best friend. So now that we've looked at some of the misconceptions of the general public, let's look at the current mental health care system. Our current mental health care system is failing in 3 areas: training, accountability and regulation, and fragmented care. There's a gross lack of quality control among health providers. Evidence-based treatments do exist, but too few clinicians are actually trained in them. Over 60% of professional schools of psychology and social work offer no program, social work problems, do not include any supervised training and any scientifically based therapy. Therapy is hard. It requires learning, which requires motivation and practice. And getting people to therapy is hard, either because they don't believe they need help, they've succumbed to the stigma of mental health, they can't afford it, or they're on a wait list to see a provider. What a disservice it is when they finally get there if the clinician is poorly trained in the modalities that are proven to help them. Further, providers are working beyond the scope of their training. offering to treat conditions such as post-traumatic stress disorder with little to no evidence-based modalities at the risk of re-traumatizing their clients. When we don't measure outcomes, confidence outpaces competency and credibility. If your appendix was rupturing, wouldn't you expect the person who's treating you to have some appropriate form of surgical training? This leads to accountability and regulation. If you look at almost any physiological illness, you will find that there is some measure for quality of care. We do not see this with mental illness. Imagine treating diabetes without testing glucose levels. Too few clinicians have treatment plans that track or measure progress, and no one is holding them accountable to do so. In British Columbia, counseling is not regulated, and as such, they are not designated as healthcare professionals. I will say that Adrian Dix has just come out and in the last few weeks and said that they are going to regulate counselors in British Columbia. It will probably take 2 to 3 years for that regulation to take place. In the meantime, anyone can hang a sign on their door and call themselves a counselor. The lack of regulation is putting all counselors in the same uniform and making it extremely difficult for the consumer to know exactly who the experts are. That would be like going to the hospital, you know, with your appendix rupturing and one of the nurses or the paramedics offering to do that surgery for you and you not understanding that it wasn't the physician because they're all wearing the same outfit. These are all designations for counselors in British Columbia. Can you tell which of these have 7 years of training, 4 years of training, or 7 months of training? And do you think that the people living with serious mental illness or their distraught families have the capacity to understand the difference? Lack of regulation leads to the absence of consistent quality control. This is not in the best interest of the public, especially vulnerable populations who live with serious mental illness and are often incapable of organizing collected action to work in their own best interest. Finally, the care system is fragmented. Service providers aren't working with other professionals in an efficient way. People are used to working in closed systems. They're focused on short-term relief rather than recovery. When a person presents to an emergency room with symptoms of a mental illness, they are often too quickly discharged back into the community without a coordinated follow-up plan. The risk for patients hospitalized for suicide attempt and/or psychosis goes up dramatically upon their discharge for the next 7 days. Yet these patients are often receiving no follow-up care with a mental health care professional. Doctors are struggling. Mental health care providers are struggling. Care needs to be coordinated, and it should include family, peer supports, caseworkers, and mental health care providers at a minimum. No one who is in the hospital for suicide attempt, suicide ideation, or psychosis should ever be discharged without a community-based safety plan, crisis line phone numbers, access to food, medication, housing, transportation, and a follow-up with a mental health care provider. Likewise, mental health care professionals too often do not have collaborative relationships with their physicians to ensure a full circle of care. Treatments for mental illness are rarely combined, coordinated, or optimized on patient need. The more coordinated the treatment plan, the better the outcomes are for that patient. Mental illness is the largest inequality and crisis in healthcare. The crisis is not going to be solved by one sector of care. It will take a village, a tribe, a community, and a country. So I know that was a lot to digest. So just take a deep break, deep breath, and I'm going to take a drink of water. And now we'll start to talk about solutions. So we need to start with a trauma-informed system. And we need to recognize that this is a complex process. It's not just a catchphrase for websites. Engaging in the principles of trauma-informed care is critical to establishing trust and avoiding re-traumatization. Here is a very brief overview of what a trauma-informed system needs. Number one, it needs safety. The neurobiological impact of trauma on the brain can result in an acute inability to feel safe. It's like having a fire alarm that constantly goes off in the brain, but there's no fire. Consequently, they can become chronically engaged in a fight, flight, or freeze state. As we create resources to help provide safety, we need to remember that the traumatized brain will always unconsciously seek what is familiar over what is safe. So lack of engagement with a system could be a symptom of that state. So if you're creating programs and you're creating resources for individuals living in poverty, if you're not getting engagement, this might be one area to look at. Sometimes we just have to be a little more creative about how we introduce services. Number two is transparency and trustworthiness. Remember that mistrust of others is a common symptom of post-traumatic stress. And if someone is living in poverty, it's such a high likelihood that this individual has experienced trauma in their lifetime. So your policies and your programs need to have some level of transparency, and they need to be honest. Feedback and collaboration. What is your feedback? What is your process for measuring feedback? A trauma-informed organization gets feedback from and collaborates with the population they are serving, as well as other social sectors making attempts to service the same population. Empowerment and choice. The ability to use one's voice is often disrupted by traumatic events. Including them in your team helps them restore their voice. As a little bit of humor, but also it's a fun fact, I guess, trauma will dysregulate areas of the brain that are responsible for speech, for verbal expression, but it notoriously leaves one area of the brain online called Wernicke's area, and this is the area of the brain that allows us to swear. So sometimes it doesn't feel like they're struggling to communicate how they feel. Intersectionality. Some types of trauma are disproportionately experienced by certain groups because of deeply entrenched structural inequalities. Training everyone in your organization that the effects of trauma are not equally distributed among people, as well as training them in cultural competencies, microaggressions, bias, active listening, and psychoeducation is trauma-informed. Without proper training, you cannot call yourself trauma-informed. When we look in terms of trauma being disproportionately experienced by certain groups, you can see here only 1% of Canadians will qualify for a diagnosis of post-traumatic stress disorder. 2 to 10% of Canadian military veterans will qualify for PTSD, with 50 to 64% of Indigenous Canadians will qualify for post-traumatic stress disorder. Number two, the earlier the intervention, the better. The better the individual's trajectory of care. Remember that the majority of mental illness symptoms emerge prior to the age of 25. Early intervention programs should resource parents and children all the way through development. The importance of early intervention cannot be overstated. The economic impact of child maltreatment is estimated to be $124.6 billion. Comparatively, the total cost of the top 5 pediatric health problems equals $100.3 billion. Just a small reduction would save $1 billion. That's good financial incentive to invest our resources into parents, children, and families. Number 3, we need a community human rights agenda, community-based, human rights agenda. So let's consider the following. People living with mental illness are citizens who deserve dignity and respect. For those living with mental illness, this feels like I have choices and I can do this. People living with mental illness have the right to be included in the community. For those living with mental illness, this feels like I am protected and I can do this. People living with mental illness deserve opportunities to work and play within the community. For those living with mental illness, this feels like when I perform acts that are useful to others and they show appreciation, I experience purpose and care. All people, including those living with mental illness, function best when we preserve their freedom and play to their strengths. This creates an inclusive social fabric that welcomes all people involved to create purpose and meaning in their lives. To those living with mental illness, this feels like I am capable and I can do this. Family involvement and interpersonal relations are valuable and necessary resources for recovery from mental illness. This is a bi-directional road of healing where who saved who disappears into a destigmatizing mindset that is caring and inviting. Improved living conditions are a necessary social determinant for health for recovery. One cannot heal when their hands are bound and surviving basic human rights, such as access to food, clean water, and shelter. Involuntary treatment, seclusion, and closed doors are violations of this agenda and should be the exception, not the rule. Dr. Insel shares that people living with mental illness need 3 things for recovery: people, place, and purpose. I recommend this be the basis of your action plan that follows your human rights agenda. Number 4, coordinated services. Over the last, as a community, it is your job to figure out how to coordinate different sectors of care to deliver services in an impactful way. We often see different social sectors working effectively on solutions within their area of specialization. However, those social sectors are often not working together. As a result, we fail to deliver our services in an impactful way. All of these organizations could and should be working together. Remember that coordination among systems is how we make a greater impact. It always makes me sad when I go into meetings and, the RCMP aren't there or the paramedics aren't there. We all want to work together. Number 5, community mindset. Family and community are not just important, they're vital variables to a long-term coordinated care plan. Their voices are important and they need to have a place at the table. Mental illness is a community problem, a national and global problem. When we look at the rockstar communities that are tackling mental illness and poverty, there is one metric that measures how successful they are: the community mindset around mental illness and the extent to which they collectively open their doors and collaboratively work on the issues. These ideas are not academic. They've already been put into practice around the world. When I worked as a crisis counselor in Colorado, we had a very sophisticated system that made great efforts towards this. When the police were called, a mental health counselor professional showed up with them. So we were dispatched at the same time. When someone presented to an emergency department with a mental health crisis, the physician called a counselor to come evaluate and coordinate a trauma-informed response. As a crisis counselor in Colorado, my job was first and foremost to evaluate the needs of the patient, to coordinate with law enforcement or school administrators if I had been called into a school, and with emergency room physicians, as well as the patient's families. If I made the decision that hospitalization was not appropriate, then I was responsible and liable for creating a discharge safety plan that followed that patient through the upcoming weeks, ensuring that they had access to follow-up care. If I decided that they did need to go to a psychiatric hospital, I was responsible for and held accountable to ensuring that he or she had wraparound care and was handed off to another professional or a group of professionals, be it a hospital or a community-based team. Similar to my experience in Colorado as a crisis counselor, in New York State, there are coordinated specialty care programs designed for youth during their first episode of psychosis. The program combines psychotherapy, medication management, family education and support, case management, and work or education. The teams include family members as much as possible. One of my favorites is beginning in Africa and then expanding to other areas of the world, such as London, England. We see a community-based peer response program known as the Friendship Bench. This is a friendship bench in front of health clinics that is staffed by grandmothers who are trained in basic listening skills, cognitive behavioral therapy, and a technique called behavioral activation. The grannies get a few weeks of training and then support people through loneliness, depression, and anxiety. They're provided with cell phones that they can use to call more experienced clinicians who are available to support them. One of my favorite things about this is that there's a lived wisdom there as well, not just the training that they get, but you see a lived wisdom from someone who's been through life and can help support from a different informed place, which I just love. In California, there are clubhouses that are intentional communities that provide more than just transitional housing from the hospital. These are places where each day you can socialize with other people, you can eat together, you can participate in organized activities and get support finding work. The houses exist in ordinary neighborhoods that are part of the larger community. Finally, the World Health Organization names Trieste, Italy as the world standard in community psychiatry. The Trieste model has proven its worth, its safety, its practicality, its community mindset, and cost effectiveness. If all you did was study Trieste model, you'd be well ahead of a lot of places. The deinstitutionalization of psychiatric beds in Trieste worked because society opened its doors in response. They provide supportive housing, 24-hour community centers and crisis response, home care, social clubs, paid jobs, and the entrepreneurial companies that are created and run by the Trieste mental health care system. Recreational, sorry, that's my dog. Recreational opportunities and social service help obtaining economic assistance. Families and friends are welcomed into the environment, and an environment that is beautifully and mindfully and creatively planned. The atmosphere is very normalizing and it promotes a sense of belonging. As an outside visitor, it would be difficult to discern who is a member of staff, who is a patient, or who is a family or a visitor. And they don't stop there. Honoring that recreation and pleasure are an important part of living, the centers sponsor parties, trips, exercise, and art and theater workshops. Community services follow the user home to hospitals. Follow the user to home, to hospitals, to nursing homes, and even into the prisons. Home visitors learn about living conditions. They help mediate conflicts with family or neighbors. They help administer medication, and they accompany people as needed to government agencies or to the workplace. So I know what many of you may be thinking. That sounds really lovely, Jen, but it also sounds really expensive. But the mental health care crisis is already shockingly expensive. Right now, Canadians are paying for mental illness in the most expensive way possible because we're waiting too long to provide access to treatments that we know work. We're waiting until people are suffering from mental illness and are in crisis. And we're relying on an inadequately resourced, fragmented, unregulated, and untrained workforce to provide the most expensive care: hospitalization, medications, and incarceration. Each one of these people has a treatable mental illness. The annual economic cost of mental illness in Canada is estimated at over $50 billion per year. That does not include the economic cost of substance abuse, which is another $40 billion per year. In British Columbia alone, it is estimated that mental health problems cost our provincial economy approximately $6.6 billion a year. We really can't afford to keep going like we're going. Some of you may also be thinking, okay, but it also feels like the ship is leaking in too many places and it feels overwhelming. So I would like to leave you with a story of hope. My story begins with lymphoblastic leukemia, a disease that affects children between the ages of 2 to 5, and among physicians is known as ALL, which can also stand for All Kids Die. In the 1970s, the mortality rate of ALL was 90%, and the process of dying from ALL was horrific for everyone involved. 40 years later, ALL is 90% curable. There was no magic bullet, no new medications that resulted in this change. Originally, the chemotherapy combinations resulted in remission for 80 to 90% of patients, but then they relapsed and died. What they learned was that they needed to use the treatments they already had continuously, aggressively, and for longer periods of time. Instead of weeks, they were in treatment for months and sometimes years. Remember when I said that we have treatments that work, but we're too focused on short-term symptom reduction over long-term recovery? Does this sound like a familiar parallel? But they didn't stop there. Every child diagnosed with ALL was enrolled in a research study that was a continued commitment to improve care for the next generation of children. Outcomes were longitudinally measured. Physicians and hospitals were held accountable for ensuring quality care, and researchers towards the greater pursuit of knowledge. In closing, we have more medicines, more treatments, more people working on the problem, more people entering into treatment, and more people suffering and dying. We don't need to wait on science to create another medicine, another treatment modality, any breakthrough understandings of genetics, or more cultural awareness of mental health to start making better progress. And we won't make significant progress on poverty until we also address the mental health care crisis. The example of ALL reminds us that when we are better at utilizing the resources we already have, we can make great strides while waiting on those breakthrough discoveries. To the valuable people in our communities living with mental illness, they do not need a breakthrough in medical science or psychiatry. They need social connection, somewhere safe and consistent to go to, and a sense of purpose. Tribe is the best medicine, as it is in and of itself, people, place, and purpose. And finally, to my people, my darlings and my loves, the ones who bravely face the day burdened by mental illness. I see you, I hear you. You are important and you are valuable. You are not your mistakes, you are your potential. Healing and recovery from trauma is letting go of the stories that were never yours to hold. The judgments, the criticisms. It is a returning back to yourself with a new understanding that you are always enough. The pain you live in is treatable. But the path to recovery is hard, but you already know hard. And hell was made for heroes to walk back through the flames and find water to help your brothers and sisters who are still burning. Sorry. That's okay.
That's okay, Jennifer. Thank you so much. And I just think you have so strongly emphasized the need for a whole community approach, and I think which is a change in systems. And I think that you've it's so important that we already have you know, everything at our fingertips that to help people, but it's more just like a targeted, more meaningful collaboration to bring everything together. So one of the questions that we had in the chat here is that, you know, mental illness and poverty, the connection between the two of them, it's almost like a chicken and an egg in a way, because we know that poverty impacts mental illness, and that mental illness often results in poverty. So do you just have a comment on that, the whole concept of the duality and the interrelationship between the two?
Yeah, it's very true. You know, we know that it has long been known that your zip code has an influence on, you know, your statistical likelihood of developing mental illness. But I guess where I would comment on that is that early intervention, working with children, working with families is really the best way to get in and break that cycle, right, as best we can. When you look at the adverse childhood experiences and the Kaiser Permanente studies on that, and all of those statistics are listed with the CDC, it's incredible. I'm hesitant to quote, because I want to say that they said if you reduced adverse childhood experiences, I can't remember, they gave you like a certain percentage, you could reduce the opioid crisis by 75%. Because just think of the economic benefit of that. And it starts really with like helping children and families, right? And so I guess my comment there, Jill, is absolutely there is a relationship there. There's generational transmission of trauma on a genetic level. We can genetically transmit trauma through DNA methylation, but we really just want to resource children and their parents as early as we can.
Well, and that's just like you did mention that most mental illness, the symptoms of most mental illnesses do emerge very early on in life. So that like being able to identify those signs and symptoms early, but have the systems in place that are qualified to recognize that, I think is really critical, followed with the community supports to be able to address it.
Yeah, I think right now, oh, sorry, go ahead.
Well, I think, and this comment just relates directly to that, and just that there's a need for thinking around prevention-based community level protective factors. Mm-hmm. And so that this requires a multi-sectoral approach that avoid people working in silos, like I think you mentioned early on. And just so that, you know, one of the key things is like an interministerial or interagency approach. And they were just wondering if there's any studies or examples from other cultures or countries that have been very proactive in kind of that interagency or interministerial approach.
Yeah, you'll find pockets of them. I think Trieste is the best because it's just stood the test of time, and it's just our best model really to learn from. But for example, in Colorado, when I worked as a crisis counselor there was a lot of like, you know, if you were working with a child, someone else was working with the parents, but then there was a whole nother level of providers up here that were trying to find resources for both. And then you'd have the family counselor come in and bring them together, right? So it's like the whole system working together. If you needed, you know, vouchers for the bus, or you needed, in the States, we call them food stamps. if you needed food or you needed shelter, there was always a case manager working on that, right? So you kind of had case managers working on survival things, like how to fill out forms for disability, how to find housing and food and transportation. But then you had therapists and physicians and psychologists and psychiatrists, and they're all seeking permission to speak with each other, right? And they might even outsource. We had a group of people that would outsource for certain students. We'd say, well, this child would really do well with equine therapy, right? And so we would outsource into the community. We'd pay for that opportunity for them. But then the person who was doing equine therapy with them was brought in, right? And they were part of the team then. So nobody was acting in like these independent silos. And so I think you'll find it's hard to find them. But there are communities that do really well with that. And I think probably the easiest for you to study, because the most research has been done on, is Trieste.
Well, and I just loved what you said about people who experiencing this mental illness being part of the creation, like being at the center. So, yeah. And part of the creation of solutions.
Yeah.
And the another question is just wondering about the connection between the impact of the toxic drug crisis in terms of increases in the mental health crisis, kind of so the link between those two.
I think that the drug crisis is a symptom of the mental health crisis.
Yes,
for sure. And I mean, all behavior is communication. When you look at, I mean, these people are demonstrating to you how much they believe in themselves, how much they love themselves. They're showing you with their action, their pain. And oftentimes we don't see that, right? I mean, if any of you have children and you've raised, I have 4 kids. And so I've done adolescence probably more times than I should have, but adolescents can be a really good example of, boy, sometimes they don't act in nice ways. They seem to be maybe ungrateful or really kind of self-centered, or, but you're kind of, I always tell my clients, parents, it's like raising teenagers is like mental judo. When they push, you pull in, right? And I think it's the same with the mental health and the substance use crisis. When they push, you pull in, right? And we have to face our own biases and our own wounds that get defensive and reactive, or want to avoid and not participate in helping those people who are struggling with addiction or mental illness. Sorry, that was probably really complicated answer. I apologize.
Well, no, it's just, I think that for me, what it really points to, Jennifer, is just that increased awareness of how we need to, how the kind of the impacts or the outcomes, the consequences that we're seeing in society are really a result, they're symptoms. And so we need to dig back into the root causes of those symptoms in order to be really effective. Are you familiar, Lisa from New Westminster has brought up the communities that care model in BC. I think it's a model that's being rolled out in a few communities across the province.
I'm not, but I'd love to know more. So communities that care?
Yeah, communities that care.
Okay, yeah, that would be great. Thank you for.
Yeah, it's a model, I believe, and please someone jump in and correct me if I'm wrong, that is really targeting youth in particular. And yeah. So it's a prevention model that, and hopefully, I think with this increased awareness, that, we're just hoping to kind of co-generate conversation around what needs to shift in our society in order to be more effective. And the comments that you made earlier about stigma, I think are just critical. because, you know, that's very true with poverty as well, and just how poverty, mental health, stigma, they're all interconnected. So we're coming to the end of our call. So I'll just, we have a few closing announcements, so Dave, if you want to stop sharing your screen, and Maureen will share her screen again, and we'll talk about some upcoming learning opportunities. We're really excited about our upcoming event in late April, our annual event. And it really is just based on what we've heard from communities, and we're just hoping to really elevate a whole bunch of conversations around helping people strengthen their own, you know, we try not to use the word resilience, but their own capacity and strength to weather the storms that we've all been facing at the individual level, at the organizational level, the community, the whole community level. And we're hoping we'll also be bringing in some of our other vibrant communities partners to lead workshops on these issues. And at the end of January, we have a webinar on the local government contribution, a game changer for positive social change. And again, this is really looking at the local government role in helping to address complex issues. So this one should be good. So mark your calendars for that as well. So we will be sending out the recording and some notes and resources after the call to everybody. And just once again, Jennifer, I'd really like to thank you. It was really meaningful, and it just helps to put things into perspective that when we're talking about systems change, we need to go deep. And in order to be effective, we need to think differently about things that we have been trying to address for years. So thank you once again, Jennifer, for joining us on the call and your excellent presentation. And thank you for everyone who joined us today and for your questions. We really appreciate your participation.